Okay, we're going to do the virtual simulations for the mock code day. So this is the EKG simulator that you were supposed to do your homework on for the EKG. So we're going to use this simulator to review the mnemonics for code management. So this should be the last of the series of 4 videos that you're watching of VoiceOver PowerPoint. So this should be the last one that you watch. And on this one, we're going to apply what we learned. And I think this will help you for the actual mock code. So let's do this together. So I'm going to the settings and I'm going to make it 8 minutes. I'm going to make it static. I'm going to turn off the sound. And we're going to play the game. Okay, so this is, oh, I guess we start again. Okay, so this is more P waves than QRSs, so it's some sort of a block, right? And this here is got a P wave with no QRS. So we got more P waves than QRSs. So the first thing you do is when you have more P waves than QRSs is determine are the PR intervals constant? Is this PR interval the same as this PR interval, the same as this PR interval? And the answer is obviously no. So it's not type 2. You can rule that out. So now it's either Winky Bach type 1 or it's third degree heart block. So if it's Winky Bach, it's going to get, the PR intervals are going to get longer and longer, and then you're going to get a P wave with a drop QRS. And so here we have a P wave that's normal. It looks like the PR interval. And then here we have it gets longer. And so you can see there's a pattern, right? So this one's longer than this one's longer than this one, and then you got a P wave with a drop QRS. So this is second degree type 1, also known as Winky Bach. No treatment necessary, just watch them. Here we have a pacemaker spike, right? And it's front of the P wave, so this is an atrial pacemaker. So this looks like it's working well. We got 100% capture. Why do I say I have 100% capture? Because after every spike, there's a P wave. So every spike is initiating an electrical response by the heart. So I have 100% capture because every spike is followed by a P wave. So this is paced atrial and everything seems to be working properly. This is an idioventricular rhythm, and we're not discussing idioventricular rhythms. Okay, so this is another one that you have more P waves than QRSs, so you obviously have some sort of block. So now you got to determine, are the PR intervals constant? Is this PR interval the same as this PR interval, the same as this PR interval, the same as this PR interval, and the same as this PR interval, and the same as this PR interval? And if the answer is yes, then it's second degree type 2. And the answer here, I can eyeball it and see that it is constant. You could measure the PR intervals, but I can eyeball it and see that it's about, no, about 4 or 5 little boxes, probably 5. And so everything, but they're constant. So this is a second degree type 2. So again, when you have more P waves than QRSs, determine if the PR intervals are constant. And if the answer is yes, it's type 2 and you're done. Treatment is a pacemaker. So this patient would need a pacemaker. This is PVCs, premature ventricular contractions. So these are narrow complex QRSs. So these are coming from the atrium. These are wide and bizarre. So they're coming from the ventricles. So this is normal sinus rhythm with PVCs. Now, when you have frequent PVCs, it can lead to VTAC. And the treatment for frequent PVCs is lidocaine. Lidocaine. So here the doctor might order lidocaine. Lidocaine is an antiarrhythmic that works only on ventricular arrhythmias. So normal sinus rhythm with PVCs, the doctor might order lidocaine if they're frequent. This is paced ventricular. So here we have a pacemaker spike followed by a QRS. And again, we have 100% capture because every spike is followed by a QRS. So everything seems to be working properly. So this is paced ventricular. Here I have upside down P waves right before the QRS. So this is a junctional rhythm, but the rate is 82. So this is accelerated junctional. If it was between 40 and 60, I would just call it junctional. But because it's between 60 and 100, I call it accelerated. If it's over 100, I will call it junctional tachycardia. So this is accelerated junctional. No treatment necessary. This looks like PJCs. So a normal beat, and then a premature beat. Normal beat, normal beat, normal beat, normal beat, premature beat. And the premature beat has a P wave that's upside down following the QRS. So this is a junctional beat. So this is normal sinus rhythm with PJCs. No treatment necessary. Okay, so what's going on here? So it looks like I got either a sinus arrest or a sinus block. Because how do I know it's sinus? Because there's one P wave in front of every QRS and they all look similar. So this is a sinus rhythm, but I'm having these pauses. So now I got to determine is it a sinus arrest or a sinus block? So if it was a sinus arrest, then it would not start back on time. If it was a sinus block, it would start back on time. So what you can do is you can take a piece of paper on your screen and measure the distance between two tick marks and then march it out. You can use I use a Sharpie on my screen to march it out. You can do that if you like. But this is either sinus arrest or sinus block. I'm going to guess I'm not going to march it out. So I'm going to eyeball it, and it looks like it probably does start back on time. So I'm going to guess that it's a sinus block. Now, the heart rate is 54. This person's heart rate is 54, so they do have some bradycardia. They may or may not be symptomatic. So what is the mnemonic for symptomatic bradycardia? Pacing always ends danger. So somebody with a sinus block or sinus arrest that has long pauses, the doctor might order a pacemaker. And if they have symptomatic bradycardia, again, the mnemonic is pacing always ends danger. So what does that mean? You're going to put the pacemaker pads on them. So we have what's called transcutaneous pacers that can be used in an emergency situation. So you have pacer pads that you're going to look at, make sure they have pacemaker capabilities. You're going to look at the picture and put the pads on according to the instructions on the pads. And then you're going to set the defibrillator monitor to pacer mode, and you're going to set the rate, the output, and the sensitivity according to the doctor's orders. And so pacing, always, the always stands for atropine. Atropine is the drug of choice for bradycardia. It is used for nothing else but bradycardia. So in this case, you would give atropine 0.5 milligrams if they were symptomatic. And what do I mean by symptomatic? If they were symptomatic, they might be diaphoretic, they might have hypotension, they might be complaining of chest pain, they might be short of breath, right? So you only treat symptomatic bradycardia. With a heart rate of 54, they're probably not symptomatic. They may or may not be. But if they were symptomatic, you're going to give them atropine, 0.5 milligrams IV or intraosseous. And so you can give them up to 3 milligrams. So that would be up to 6 doses, right? So 0.5 times 4 is 8. So let me see, 0.5 times. So we said the max dose is 3. So you can give them 3 milligrams. So you can give them 6 doses would be the max amount of doses you could give. So 5 minutes, every 2 to 3 minutes, you can give half a milligram, up to 3 milligrams. And so the doctor might order the atropine, right? So you're going to give atropine 0.5 milligrams IV push. Atropine is one of those drugs that can be given via the ET tube. Remember, naval, right? So the A in naval is atropine. You can give atropine in the ET tube if they do not have an IV. So Pacing always ends danger is the mnemonic for symptomatic bradycardia. So you slap the pacer pads on them, and then you've given them the atropine, 0.5 mg IV push. You can do that every 3 to 5 minutes until you've reached the max dose of 3 mg. Once you've reached the max dose, you can start the pacemaker. Right before, you just prepared them for pacing. You slap the pacer pads on them, and you prepared them for pacer. But then you're going to give them atropine. Atropine is going to be given every 3 to 5 minutes, IV 0.5 mg, up to a max dose of 3 mg. If that didn't work, they're still bradycardic, then you start the pacemaker. And if that didn't work, then you can try an epinephrine drip. And if that didn't work, then you can try a dopamine drip, medium dose. Pacing always ends danger. That's the mnemonic for symptomatic bradycardia. Okay, so what do we got here? Looks like we got normal sinus rhythm. So this is normal sinus rhythm. What if they did not have a pulse? Then we would call that pulseless electrical activity, right? PEA. PEA is when you have electrical impulse on the monitor. You have an electrical um, um, graph on the monitor, but there is no pulse. There is no heartbeat associated with that rhythm. So the patient is, if when you listen to their heart rate, they have no heart rate, they have no pulse, but there's an electrical activity on the monitor. It could be normal sinus rhythm, it could be sinus brady, it could be AFib, it could be any rhythm, but there is no pulse. That's PEA. And the mnemonic for PEA is PEA. P stands for problem. What is the possible problems for pulseless electrical activity? And in a minute, we'll go over that mnemonic. There's a mnemonic for that, right? Which is patch 5MD. And we'll go over that mnemonic. So you figure out what the problem is. Once you figured out while you're trying to figure out the problem, all you can do is give them CPR, bag them, give them epinephrine every 3 to 5 minutes. And if it's a Brady rhythm on the monitor, you can give atropine. Remember, atropine is only given for Brady rhythms. So in this case, with a heart rate of 72, I would not give atropine. So all I could do is figure out what the problem is. As I'm trying to figure out what the problem is, give them epinephrine every 3 to 5 minutes as I'm doing CPR and bagging them. That's all I can do. Once I figured out what the problem is, I can try to fix the problem. So what's the mnemonic for the problems that cause PEA? Patch 5MD. So what's the P stand for? Pulmonary embolus. So what are the signs and symptoms of a pulmonary embolus? All of a sudden, they're going to be short of breath. It's going to hurt to breathe, and they can go in and give a thrombolytic to treat that, right? So a pulmonary embolus. Patch, the A stands for acidosis. So if they're acidotic because it's a metabolic acidosis, I could give them bicarb. If it's a respiratory acidosis, I could bag them. I could hyperventilate them to blow off that CO2. You could also, if the reason why they're so bicarb, and you could bag them. So patch, PAT. What's the T stand for? Tension pneumothorax. And what's the treatment for that? An emergency thoracentesis, where they're going to go in and get the air out of the pleural space. Patch, cardiac tamponade, emergency pericardiocentesis. And the H, the 5 H's, hypovolemia, give them fluids. Hypoxia, give them oxygen. Hypothermia, warm them up. Hyperkalemia, you can give them insulin to pull the potassium back into the cell. But if you're going to give them insulin, you're going to have to give them glucose so they don't get hypoglycemic, right? And if the reason why they have hyperkalemia is because of the acidosis, you can give them bicarb. Let's see. So you can give them insulin. You can give them Kayexalate so that they poop out the potassium. So hyperkalemia, hypokalemia, you're going to give them potassium. So patch 5, M stands for massive MI. So you would possibly put them on a intra-aortic balloon pump to treat the cardiogenic shock. And drug overdose is the D. So hemodialysis or charcoal so that they throw up the contents. All right, so this is normal sinus rhythm, but if there was no pulse, then we would call it PEA. All right, so I believe that this is I think they call this a sinus arrhythmia. So this is where it speeds up and slows down with the breathing. No treatment necessary. All you need to know about sinus arrhythmia is that it occurs often in children. No treatment necessary. It's where your EKG is associated with your respirations. It slows down and speeds up with exhalation and inhalation. SVT. This is what this is. SVT, supraventricular tachycardia. Why do I know this is SVT? Well, the heart rate is at 180. It's narrow complex, and there is no P wave. I can't see the P wave. If I could see the P wave, then I would say that it is sinus. But I can't say it's sinus because there is no P wave. So I know it's coming from somewhere above the ventricles because the QRS is narrow. But the rate is really fast. It's 180. This person's probably symptomatic. They're probably short of breath. They're having palpitations and so forth. So for this patient, the treatment of choice is adenosine. Before you give them adenosine, you might try a vagal maneuver. So remember VAC, VAC, vagal maneuver. Try a vagal maneuver first. That can slow down the heart rate. If that doesn't work, then you give them adenosine, 6 milligrams rapid IV push. Why do you give it rapid IV push? Because it has a very short half-life. Adenosine only has a half-life of about, I think it's 10 seconds or something close to that. So if you give it slowly, by the time it gets to the patient, it doesn't work anymore. So what happens is that it causes asystole. So it's kind of scary when you give it because it stops the heart, and you'll see asystole on the monitor. The asystole only lasts about 10 seconds, and then the heart should restart again. And the hope is that the sinus node will take over when it restarts. So right now, the sinus node is probably not the pacemaker of the heart because it's going so fast. So the hope is that when it restarts, the sinus node will take over as the pacemaker. So you give them adenosine, 6 milligrams rapid IV push. If that doesn't work, then you can give them 12 milligrams rapid IV push. And if that doesn't work, then you can try cardioversion. If the doctor says, let's prepare for cardioversion, the mnemonic is, oh, say it isn't so. What does that mean? You're going to start them on oxygen. You want to make sure that there's an O2 sat monitor on the patient. Say suction equipment available. Make sure they have a patent IV. It isn't is make sure that they have intubation equipment available. And so is sedate them if possible. So if their vital signs can handle it, you're going to sedate them because you are about to shock them and that hurts. So if you can, sedate them and maybe give them a pain med before you cardiovert. Remember, whenever you cardiovert, you have to hit the sync button, the synchronized button. That's the main difference between cardioversion and defibrillation, is that you hit the sync button. What happens when you hit the sync button is that when you hit the button to defibrillate, there's going to be a pause. The machine is not going to shock them right away. Why? Because it's waiting for the next QRS. It's going to shock on the R wave. Why? Because if it shocks on the T wave, the patient will go into asystole. So people that are being cardioverted, you're going to hit the sync button. It's going to be synchronized so that when you hit the button, it's not going to shock right away. It's going to shock on the next R wave. Always do the clearing chant whenever you cardiovert or do defibrillate. You always do the clearing chant. What does that mean? 1, I'm clear. You make sure you're not touching the bed. 2, you're clear. You look at the people that are giving CPR and the people that are bagging the patient. You look at them and say, 2, you're clear. Make sure they're not touching the bed. And then 3, everybody clear. You look around and make sure that nobody is touching the bed. So VAC for SVT. Vagal maneuver first. If that doesn't work, adenosine 6 milligrams rapid IV push. If that doesn't work, 12 milligrams rapid IV push. And if that doesn't work, cardiovert, VAC. Okay, so here we have a pause again with a heart rate of 48. So remember, if it's symptomatic, you're going to do the pacing always ends danger mnemonic. So this looks like it, I don't know, it looks like it might start back on time. So sinus block starts back on time. Right. So why is it sinus? Because there's a P wave in front of every QRS and they all look similar, but there's a pause. If it starts back on time, it's a block. If it does not start back on time, it's a sinus arrest. This is accelerated intraventricular, and again, we're not talking about that rhythm. What is this? This is AFib. It's obvious that it's AFib. You see the fibrillatory waves. It's irregular, narrow complex with no discernible P waves. And here you have coarse fibrillatory waves. The rate is 90, so it's controlled. Yes, it's irregular. So AFib. So if this was new onset AFib, the doctor might cardiovert. If they've had AFib for years, cardioversion is not going to convert it. But if it's new onset, cardioversion might convert it back to sinus rhythm. So if they've been in this rhythm for more than 48 hours, they need to anticoagulate with a heparin drip before they cardiovert. Why? Because if it's been in this rhythm for more than 48 hours, they've had time to build up a clot in the atrium. And so what you want to do is start them on a heparin drip and until the heparin is therapeutic. And once that heparin is therapeutic, what is therapeutic? 2 to 3 times the baseline. The APTT or the PTT is 2 to 3 times the baseline. That's when it's therapeutic. Once it's therapeutic, you can cardiovert. So you're going to start them on a heparin drip if they've been in this rhythm for more than 48 hours. Okay, what's going on here? This looks like PACs. So I have a normal beat, and a premature beat. Normal beat, premature beat. Normal beat, premature beat. And the premature beats have a P in front of them, so it's a premature atrial contraction. So normal sinus rhythm with PACs, no treatment necessary. All right, I got more P waves than QRSs, so I have some sort of a block. So the first thing I do is I look to see are the PR intervals constant, and obviously they are not. This one's much different than this one, and it's different from this one. So they're different. Here I'm seeing P waves where they don't belong. If I were to march it out, I'm probably going to find a P wave here. Here's another P wave. Here's another P wave. There's another P wave right after the QRS and the T wave. Another P wave that doesn't belong there, right? So you have, and here, if you march it out, you're going to probably find a P wave here. So you're finding P waves where they don't belong. You're going to find P waves buried in the T waves, buried in the QRSs, after the ST segment, or in the ST segment. So you're going to find P waves where they don't belong. Third degree heart block. Treatment is an emergency pacemaker. You're going to slap those pacer pads on them and start them on a pacer mode on the defibrillator monitor. And they're going to need a permanent pacemaker. But emergently, they're going to need the transcutaneous. So this is third degree heart block. Treatment, pacemaker, emergency pacemaker. VFib. So this is ventricular fibrillation. You will never have a pulse with this. It will always be pulseless. This is a cardiac arrest. Ventricular fibrillation. So what's the mnemonic? Scream. What's the S stand for? Shock them. The first thing you're going to do is defibrillate. You always defibrillate VFib. So you're going to shock them. So if you have a biphasic defibrillator, usually the max joules are 200. So you're going to shock them at 200. So that's the S. Then there's the C. So after you shock them, you do CPR for 2 to 3 minutes. So then you do CPR. And then you check the rhythm. So we're now on the R of scream. So you check the rhythm. If they're still in this rhythm, The first time only, you shock them again. So if you didn't shock them at the max joules the first time, you're going to increase the voltage. If you shocked them at the max joules the first time, you're going to go ahead and shock them again with the max joules. So you're going to shock them again. And then you're going to go through the mnemonic again, right? So you shock them, you do CPR for 2 minutes, um, and then you check the rhythm. So if they're still in this rhythm, now you're going to give them epinephrine. You're going to give them epinephrine IV or intraosseous. Epinephrine is another drug that can be given via the ET tube if they can't get an IV line. So you're going to give them epinephrine, 1 milligram IV push. So you can give that every 3 to 5 minutes, epinephrine. So scream. A stands for amiodarone, but before you give amiodarone, remember, every time you give a drug, you got to circulate it. And after the first time, it's going to be drug shock, drug shock. So you just gave epinephrine, 1 milligram IV push. Now you're going to do CPR for 3 to 5 minutes to circulate the drug. So then you're going to circulate the drug, and now it's going to, then you're going to check the rhythm. If they're still in this rhythm, you're going to shock them again. After you shock them, you do CPR for 2 minutes, check the rhythm, and the next drug now is amiodarone. Amiodarone is the first line antiarrhythmic. So you're going to give 300 milligrams of amiodarone IV, and then you're going to do CPR for 2 to 3 minutes. So you do CPR for 2 to 3 minutes, and you check the rhythm. They're still in this rhythm, so now you're going to shock them again. Again, if you shocked with the max dose the last time, you're going to shock them with the max dose again. So then you shock them. And after you shock them, what do? You do CPR for 2 to 3 minutes. Then you check the rhythm. They're still in this rhythm. Now it's probably been 3 to 5 minutes since the last epinephrine dose. So you could give another amp of epi, right? So you give another amp of epi, and then you're going to do CPR for 2 to 3 minutes, and then you're going to check the rhythm. They're still in this rhythm. Now you're going to shock them, right? So now it's going to be drug shock, drug shock, drug shock, right? So the next time after you shock them, you do CPR for 2 to 3 minutes, and then you're going to figure out what drug to give them next, right? So what drug might be next depends on the labs. If they're acidotic, maybe I might give them bicarb. If they have low potassium levels, I might give them potassium. So you're going to be getting the labs back, and then you're going to be treating the labs. Their ABGs might come back, and they're acidotic, I might give them bicarb. Again, you're going to be then checking the labs, and based on that, you're going to be treating the problems. So VFib. This is VTAC. What's the first thing you do with VTAC? Check a pulse. Remember, with VTAC, you may or may not have a pulse. So if they don't have a pulse, you treat them just like VFib, you scream. So I'm not going to go through that mnemonic again. I just went through it with VFib. So if it's no pulse, you treat them just like VFib and you're screaming. If they have a pulse, they're probably symptomatic with a heart rate of 210. So the doctor's probably going to order cardioversion. Remember that the mnemonic for cardioversion is, oh, say it isn't so, right? So how you prepare for cardioversion. So VTAC. Okay, so here I have Winky Bach, right? It's getting longer and longer and longer, and then I got a P wave with a drop QRS. So second degree type 1, nothing. You just monitor them. Paced ventricular, you got 100% capture. What is this? Atrial flutter. You see the flutter waves, the sawtooth, the picket fence. This one happens to be, what do you call it? Regular, right? Because you got 4 flutter waves or 3 flutter waves in front of every QRS. So this is atrial flutter, and it's a controlled. Again, if it's new onset, the doctor might cardiovert. If it's new onset, the doctor might cardiovert to bring it back to sinus rhythm. If they've been in this rhythm for more than 48 hours, again, you got to anticoagulate them before you cardiovert. Otherwise, this is controlled. If they've been in a flutter, usually a flutter gets cardioverted easier than a fib does. So cardioversion, atrial flutter. Paced atrial. And here we have a pause, right? So you got, doesn't look like it starts back on time. So this would be sinus arrest, right? Does not start back on time. Nope. It must start back on time. I didn't march it out, so it must be sinus block. So if you were to march it out, it should start back on time. What is this? The PR interval looks to be normal. The QRS is narrow. Um, it looks regular. The P waves look regular. The ventricular rate looks regular. Everything's normal except the heart rate is 54. Again, symptomatic bradycardia. If they're symptomatic only, pacing always ends danger is the mnemonic. Okay, so I'm going to take a break for just a second and I'll be right back. Okay, let's do one more time around. Okay, so here we have bradycardia. They may or may not be symptomatic. Yes, everything is normal except the heart rate is less than 60. There's one P wave in front of every QRS. The PR interval looks normal. The QRS looks narrow. So everything is normal except the rate is less than 60. They may or may not be symptomatic with a heart rate of 54. Remember, you only treat symptomatic bradycardia. And what's the mnemonic? Pacing always ends danger. So what do? Slap the pacemaker pads on them, and then you set the pace the defibrillator monitor to pacer mode. You're going to set the rate, the amplitude, the output, and the sensitivity. And then you're going to give them atropine. Atropine, 0.5 milligram IV push every 3 to 5 minutes until you've reached the max dose of 3 milligrams. Atropine can be given via the ET tube. And so once you've given the 3 milligrams, if they're still symptomatic with bradycardia, then you start the pacemaker. Then if that didn't work, the pacemaker, they're still symptomatic and they still have bradycardia, then you would give them a epinephrine drip. And if that didn't work, then you would try a medium dose dopamine drip. Remember, medium dose is 5 to 10 mics per kilo per minute. And that's going to increase contractility. Dopamine is a drug that's dose dependent. You never, there's a relative contraindication to start dopamine IV because if it extravasate, it causes tissue necrosis. So dopamine should be given whenever possible via central line. Okay, so this is sinus bradycardia. What is this? This is SVT, yeah, supraventricular tachycardia. The rate's 180, they're probably symptomatic. You don't see a P wave, that's why we call it SVT. It's narrow complex, it's regular, but I can't say it's coming from the sinus node because I can't see the P wave. It's probably buried in the T wave, but I can't see it. So I call this SVT. What's the drug of choice for SVT? Adenosine. What's the mnemonic? VAC. Vagal maneuver. If that doesn't work, adenosine, 6 milligrams rapid IV push. It's going to cause asystole for a few seconds. And then if that didn't work, you're going to try 12 milligrams rapid IV push. And if that didn't work, then you're going to try cardioversion. If the doctor says, let's prepare for cardioversion, you're going to say, oh, say it isn't so. What does that mean? You have an O2 sat monitor, suction equipment available, intubation equipment available, a patent IV, and sedate them if they can handle it. Oh, say it isn't so. That's how you prepare for cardioversion. Remember, for cardioversion, the main difference between defibrillation and cardioversion is the sync button. You're going to hit the sync button. Another difference is that you get a consent form whenever possible for cardioversion. With defibrillation, they're basically dead, so you cannot get a consent form. It's an emergency. Those are the big differences between cardioversion and defibrillation. In one, the patient is dead, and the other one, the patient is awake. So SVT. This is accelerated intraventricular. We're not going to go over that rhythm. This one they're calling junctional tachycardia. So Again, their heart rate is 186, so they're probably symptomatic. So you want to slow down that heart rate. You can try a vagal maneuver. This is an SVT, right? It's above the ventricles. So you could try adenosine, 6 milligrams rapid IV push. And if that doesn't work, 12 milligrams rapid IV push. The doctor might try other meds before giving adenosine. So what are the types of drugs that slow down the heart rate? Beta blockers, calcium channel blockers. So verapamil, metoprolol, given IV. So the doctor may try some drugs to decrease heart rate, or they might try adenosine in this case. And then last resort would be cardioversion. Whenever anybody has tachycardia, you want to make sure, you're going to say, oh my, make sure they have oxygen, make sure they're on a monitor, and make sure they have a patent IV. In this patient, definitely, you want to make sure they have oxygen, they're on a monitor, and they have a patent IV. Oh my. So junctional tachycardia. This one they're calling sinus arrhythmia. That's the one for peds associated with breathing, where it speeds up and slows down with breathing. Here I got more P waves and QRSs. So the first thing I do is check the PR interval. Is this PR interval the same as this PR interval, the same as this PR interval, the same as this PR interval, the same as this one? And if the answer is yes, it's second degree type 2. And in this case, I can eyeball it and tell you that it's constant. So it's second degree type 2. It's not. Oh no, I clicked the wrong button, that's why. It's second degree type 2, not type 1. So second degree type 2. So the treatment is a pacemaker. This is normal sinus rhythm with PVCs. So these are wide and bizarre. They're coming from the ventricles. These are narrow complex. So they're coming from the sinus node, from the atrium. They're coming from the sinus node because there's one P wave in front of every QRS and they all look similar. So this is normal sinus rhythm with PVCs. If they have a lot of them, the doctor might order lidocaine. Lidocaine is a ventricular antiarrhythmic. This is first degree AV block, right? Everything is normal except the PR interval is prolonged. What drug can cause this? Digoxin. Another cause could be AV node ischemia. But basically, you're just going to watch them. There's no treatment necessary. So normal sinus rhythm with first degree AV block. Here I got more P waves than QRSs. Again, what's the first thing I do? Check to see if the PR intervals are constant. And here it's obvious that it's not, but I'm seeing P waves where they don't belong, right? That P wave does not belong there. If I were to march it out, this is probably a P wave here as well. Doesn't belong there. There's probably a P wave buried in here as well. So you got P waves where they don't belong. Once you march out the P waves, you're going to find P waves buried in QRSs, buried in T waves. And so that's third degree heart block. Treatment is an emergency pacemaker. Accelerated junctional, you've got upside down QRSs in front of the QRS and the heart rate's 82. So it's greater than 60. It's between 60 and 100, so that's accelerated junction. This is, I believe, sinus wandering pacemaker. Why do I say that? Because I'm seeing P waves that look different from each other, right? This P wave does not look like this P wave, does not look like this P wave. So I'm thinking that this is a wandering pacemaker and no treatment necessary. VTAC. Yeah, this is VTAC. First thing you do with VTAC, check a pulse. No pulse, you scream. If there is a pulse, then you might cardiovert. So VTAC. You would give them an antiarrhythmic such as amiodarone. Amiodarone is an antiarrhythmic that treats both ventricular and atrial arrhythmias. Lidocaine is only ventricular arrhythmias. Amiodarone is the first line antiarrhythmic, so you would give amiodarone probably in this case, in cardiovert. More P waves and QRSs. So I'm gonna see if the PR intervals are constant. So this PR interval looks the same as this PR interval, looks the same as this PR interval, looks the same as this PR interval. So this is second degree type 2. But there's 2 P waves in front of every QRS. So this is 2-to-1. What's the treatment? Pacemaker. AFib. Yeah, it's irregular, narrow, complex with no discernible P wave, but you see the fibrillatory wave. It's controlled. If it's new onset, the doctor might cardiovert. So again, if the doctor says, let's prepare for cardioversion, you're going to say, oh, say it isn't so. Atrial fib. Before you cardiovert them, you want to anticoagulate them if they've been in that rhythm for more than 48 hours. Sinus tap. Why do I call it sinus? There's one P wave in front of every QRS and they all look similar. Narrow, complex. PR interval looks normal. Everything's normal except the rate's greater than 100. They may or may not be symptomatic. You could try a vagal maneuver. Probably not adenosine. Usually they don't give adenosine if the heart rate's less than 150. Or they usually don't cardiovert for a heart rate less than 150. So the doctor might try other ways to slow down the heart rate, like a calcium channel blocker or a beta blocker. Vagal maneuver. Sinus tap. Okay, I got some pauses here. So if it starts back on time, it's sinus because there's a P wave in front of every QRS and they all look similar, but I have pauses. So it's either sinus arrest or sinus block. I'm going to guess that it is a arrest. It does not start back on time. VFib. I'm not going to go over the mnemonic again. It's scream. So rewind if you want to remember that one. Scream, VFib. Paced atrial, 100% paced. More P waves and QRSs. They're getting longer and longer and longer with a drop QRS. Second degree type 1, no treatment necessary. Sinus arrest or sinus block. Last one was arrest, so this one's probably block. This one is a wandering pacemaker. I got P waves that look different. Okay, so there is one more thing that I want to do to show you. I'm just going to show it to you, so maybe 3 more minutes that will be, and this video will be over. So let me share